Excellent. Well, folks, you all saw the invite. I told you just a little bit about Jane on the invite, but I'll let Jane explain as she was doing who she is, what she does for Henry Ford, and then get into her talk at will. Over to you, Jane.
Okay, thank you. Good morning, everyone. Thank you so much for having me. And Jean, I'm really glad you're on. I'd love to see your face and hear your voice, but we need to schedule another time for that. My name is Jane Thornhill. I am the Vice President of Henry Ford Physician Network and Accountable Care Organization. And what that means in terms of the work that I do under the Affordable Care Act that was brought to the country under President Obama's administration, there were a lot of work was being done with the Centers for Medicare and Medicaid to try to increase quality, increase access to good care, and decrease cost. And so one of the things that was sort of formulated out of that were called accountable care organizations. And those are physicians that come together with a similar vision to try to drive what they call the triple aim, which is increased access to care, higher quality, and lower cost. And we have physicians that are part of Henry Ford Physicians, their medical group, the employed physicians that are part of that organization. And then I also run the Henry Ford Physician Network, which is a much larger physician group comprised of low 2000s as it relates to physicians who come together for the purposes of a particular contract and try to drive those similar aims in terms of higher quality, higher access to care, and lower cost. And so you'll hear terms like value-based care. You'll hear, certainly during, I don't know that there isn't a political season anymore. I think we're just constantly in it. But when people are talking about healthcare, value to care, access to care are the things that often are being described, and that's the work that I and my team are dedicated to do. I have a physician partner. His name is Dr. Bruce Muma, and I've known Bruce for many years. He had been the chief medical officer for Henry Ford West Bloomfield Hospital when it was being built, which is on Maple between Farmington Road and Drake, I believe is where between the roads. And he is a primary care physician by background and someone who has been dedicated organizationally to value-based care and making sure that we're doing the right thing for the right patient at the right time with the right provider.
And so the transparency, Dr. Muma is my doctor.
Yes, he is. Yes, and neither Dr. Muma nor Phil remembered I was the one that got them connected. So I went back and took credit for that. And full disclosure, Jean and Phil have been dear and valued friends of mine and my husband's, our families, for a really long time. A really long time. And so, and the kids are all like, what do you mean you get to see Mr. Abraham? You got to tell them we said hello. So anyway, it's a pleasure to be able to see you. So let me talk a little bit about, I'm not a clinician. So again, full disclosure, I work with clinicians, and I can certainly hold my own when it comes to a lot of these conversations, but I always know when to guide people to the right professionals. My goal has always been to help people get good access and timely access to care. And so I do that through the connections that I have, both formally and informally. So as Henry Ford and Detroit I'm going to share my screen actually, so I can just give you guys some content here. There we go. Let me know when you can see my screen.
It's coming up now. Now
okay.
You can go full screen on that screen, so you can.
Yeah, there you go.
Awesome.
There you go. Okay, got it? Okay. Yep. Does that help even better, right?
Even better.
Even better. Okay. And so I already told you who I am, so we can move on. So I just want to share some numbers with you. And one of the things that we saw early on in the city of Detroit, southeastern Michigan, during the COVID crisis, and from the lens of Henry Ford Health System, what did I hear me, a leader within the organization, but someone who's not a clinician, what did we see? And so these numbers are related to the surge. When we saw the surge, which we, for southeastern Michigan, saw the peak of that surge on April the 7th. Henry Ford Hospital in Detroit saw patients. We had an inpatient census of 320 COVID patients. 157 of those were in the ICU. 137 of those were on ventilation, that were on ventilators. Henry Ford Wyandotte, which is downriver, had a census of 110, 40 in the ICU, 35 patients ventilated. Henry Ford Macomb, which is in Clinton Township, had 184, 60 in the ICU, 67 patients were ventilated. So basically what that lets you know is that we had more patients requiring ventilation than we had ICU beds. Henry Ford West Bloomfield, which is in our backyard from a community perspective, had 137 COVID patients, 27 in the ICU, and all 27 of those were ventilated patients. Henry Ford, a couple of years ago, purchased a Legion's Hospital, which is in Jackson, Michigan, so more of our central lower part of our state. And they saw their peak later. Their inpatient census at this time was quite low, which is 65 patients, 22 in the ICU, 11 ventilated. They actually started to see their increase in patients come later, and it was due predominantly to the fact that they have a large prison in their community, right? So there's a federal penitentiary there, and as we've heard on the news, that there's oftentimes been issues with the transmission of this virus in close proximity, and certainly a prison system would qualify as that. And I believe Dr. Faust talked a little bit about that last week when he was meeting with you all about how important it was to render care and be safe in the prison systems for those who are trying to manage that system. One of the things that we did at Henry Ford, which caught some of the news, but was more of an industry opportunity for conversation, was that we prioritized keeping our employees healthy and tested. We were testing patients and employees at the same time. So anybody who qualified for, were symptomatic as it related to a test, got it, whether you were a patient or an employee. But Dr. Muma stepped in and became the physician helping out in what we call our employee health area. And traditionally an employee health area would be, I've been transferring a patient from bed to chair and I injured my back, or I got a needle stick, or other things that would happen at work. And this is very different in terms of what happened with COVID-19. And we needed to really step up and step in to make sure that we were doing what we could to keep our employees safe and healthy. And so Bruce, my physician partner, stepped into that role quite overnight. They asked for help. He raised his hand, and where he goes, I go. And so we started to really pull together a tremendous amount of work in a very short period of time. Our health system has 33,000 employees across all of our health systems and our outpatient clinics. And one of the things that we did was make sure that we set up a system that would allow them to get tested. And so to date, and so this is for as of, I believe, last Friday when I was working on these slides, we've had 7,149 employees tested, which is, just shy of 19% of our population. A little over 1,000 of them have tested positive. And so the part that's important there is that 2.79%. You'll hear people on the news, and many of our medical professionals that are following science will say we need to keep our positivity rates below 3%. And then we had just shy of 16% of that total population that was tested came back negative. We certainly saw an incidence of employees coming back with positivity early on, and then many policies went into place to make sure that we were doing what we could to protect our employees. So our approach was to keep the workforce as healthy as we could. We deployed a 24/7 employee health hotline, so that's one of the things that I helped Dr. Muma do. So if an employee needed to report to work or was having symptoms, they could call that hotline 24 hours a day. And based on how they were screened by clinical and administrative staff members, they were directed to testing sites. And Henry Ford Health System is a place where tests can be processed. Pardon me, and the answers to those tests are within hours, not days. And again, that's something that I heard Dr. Faust talk about last week. And we really redeployed a lot of our own resources to help support others within the system. And so imagine, if you will, that, and I'll just go through this and let you know, at the peak of our surge, we had 849 patients in our hospital with COVID. And we are, as of July 28th at 4:30 p.m., we had 41. And so what we're seeing is we're seeing the numbers from the state come through daily with a much higher positivity. the good news is that's not necessarily correlating itself into hospitalizations. And so the virus is spreading, but what we've been able to do is we did flatten the curve after the surge in order to be able to keep it from having such a high demand on our hospital systems. One point we were just full with COVID patients, and it just became very difficult to manage those resources. But it is much better now. We've learned a lot, and but what we all have to do is continue to maintain social distancing, wear a mask, wear it properly when you're out in public, and make sure that we're taking these precautions, not necessarily for ourselves, but for those around us, is really how we're looking at this. And so a couple of just some stories of some things that happened within Henry Ford Health System that I think really tell a lot about the culture and the people of the organization. As I said, we redeployed people, and so a lot of things happened. Clinics started to reduce their hours due to the executive order that came from Governor Whitmer, and providers moved into more of a telemedicine environment, which means what would normally require you or I to go into the office and see our doctor is now being done over the computer or over the phone. And prior to this, many of the providers that I work with were resistant to using technology as a form of rendering care. Because of COVID-19, they were literally launched into that as a requirement in order for them to try to manage their patient population. What's been interesting is that they have embraced this now as a common practice. So I like to look at things as opportunities out of crisis. And this ended up being something that has been a very positive outcome of what was a very difficult situation. One of the other things that happened is that surgeries were paused, right? We weren't bringing people into a hospital system unless they needed to be there. So it's not to say that all surgeries stopped. There was a lot of confusion about, should you go to the hospital if you were having an emergency? The answer was then and still is yes, that's where you should be going. So, but elective surgeries that could wait without risking the patient were paused. And things like knee replacements, joint replacements where people could continue to manage, and those were put on pause until we were able to get the census down for COVID patients. Because think about it, if you go in, you have surgery, when you're done with surgery, you need a bed. If the hospital was full with other patients, it would be difficult for us to find an appropriate bed and have enough staff to take care of you. So in the interest of safety, many of those surgeries were paused. Doctors who would normally be seeing patients in their routine settings, like in an outpatient clinic or in the operating room, redeployed to help out the front lines. We had a ear, nose, and throat surgeon who was, I believe, and I need to go back to confirm this, but I believe was either exposed or experienced COVID himself. Once recovered, came back and was out in many of the hospital areas. The hospitals is where the testing sites were. There were tents for those testing sites, and he was out there testing patients and trying to take care of the patients and the staff. And then would go in and do work, because environmental services is one of the areas where we really had difficulty. We didn't have enough. There was an increased requirement of the kind of environmental service support needed. And so we had folks who were up and down the lane who had job descriptions very different than the functions that they were performing. Everyone stepped up and stepped in. One of the things that we have found is a huge need for what we're calling emotional first aid. This was an incredibly difficult time, and to have gotten through it gives a lot of satisfaction and pride, but it does not address all of the emotional and mental anguish that people went through. So we have a large cohort of behavioral health specialists and social workers that are on the floors working with the staff who were there on the front lines from the very beginning. And in one huddle, there were nurses that reported, their term was auditory hallucinations. And what that meant is that even when they would go home, they would hear all of the alerts and the alarms from the equipment from the ICU, even when they were doing their routine life at home. And so we have deployed a lot of resources to try to be of help to those folks, because just because the initial surge is over doesn't mean that the residual effects have moved on. Employees were furloughed. So I told you in the beginning that Henry Ford Health System has 33,000 employees. We furloughed about 3,300 employees. And what that meant is that if we could redeploy you, we did. If not, you were not, this is not a layoff, this was a furlough. This was saying while clinics were closed, while ORs were being paused, we didn't have work for people to do. And so the Human Resources Department had a lot of work to do to help folks. They populated banks for time off in order to, and then also help people apply for unemployment during those times. I would say of the 3,300 that were furloughed, over darn close to 3,000 of them have come back now. And we we've pulled, I think there was almost 9,000 surgeries that ended up being paused across the entire system. All of those surgeries have been pulled forward and have either people, if they've elected to continue to have the surgery, they've been performed. So we are back to normal operations. There has been an outpouring of support from the community. It was just overwhelming. Everything from restaurants wanting to make lunch and deliver it to the hospital employees to one of the things that Henry Ford did is if you were at executive level and above, so at my level and above, we gave back a percentage of our salary, and we populated a fund that would help support the other employees who were on furlough or who were having difficulty because they couldn't pay for childcare because somebody else in their household was not working. And so we gave back our salaries to help our own. In addition to that, the community itself, the donations, and just the thankfulness that it occurred. And I'm sure many of you saw this on the news when the fire and rescue cars would be coming through or other people coming through and just thanking folks who had been working for countless hours. It meant more than any social media post could probably represent. The concern for our own was paramount. We really wanted to take care of our own families, right? So folks who were on the front line, many of them very concerned about what they were going to bring home to their families. So Henry Ford did their best to put people up into hotels or apartment complexes that were close to where they were working. If those individuals didn't feel comfortable going home and risking spreading what they might have been exposed to their families. And professionally really supporting each other. We had a lot of our own staff who became ill with COVID. We lost an ICU nurse fairly early on in all of this. And so when you start losing your own, it becomes something very different for how people are handling it. Innovation was absolutely off the charts. Henry Ford has what's called an Innovation Institute. It is led by a physician by the name of Dr. Scott Dolchowski. And he is the physician who's worked with NASA to put ultrasound machines on the space station. And so we had companies and individuals stepping forward, and masks were being made. The innovation that was needed for the personal protective equipment was being led in that area, and with all the organizations and companies in town offering to help. There were care kits for diagnosed with COVID and being discharged that were being sent home with folks so that they could monitor their heart rate, their oxygenation, and things so that they could care for themselves at home. And if I go back to this, I mean, thinking about, 8,231 patients who were diagnosed with COVID have been discharged. And so, but we've lost 604 individuals patients were discharged positively, but let me back up, forgive me for a second. This is not the one that I'm looking at, but the amount of patients that we've also lost. And so one of the things that I think, so forgive me, I messed that one up. The thing that I think, there's a couple things that really stand in line. So when I was talking about the need for us to care for ourselves, one of the things that they created is what we're calling our path forward. And we have an internal newsletter. It's called the Morning Post. And they started what's called Frontline Diaries, asking people to, if they're willing, to write. And they can be anonymous. They can do what they want to tell us what their experience was. And there are a lot of them out there, but this one got me. And it's anonymous, and it says 0. For a surgery department, that would be considered a poor case count. For a supply chain rep, not enough supplies. 0 is just a number. That means little to us during our day-to-day lives, but today, 0 is very different. Today, we had 0 deaths. Nobody died. And I cried. Today, 0 means much more. And that one, I held onto that sucker, and I thought, I've never loved the number 0 as much as I did that day, and how important it was that we had colleagues, colleagues who were so excited that we actually got through a shift without a code, got through a shift without a death. And so what we did, we've spent a lot of time, many of us, myself included, grabbing onto things that helped explain it. Like, why did this happen? Why did it hit Detroit so hard? What does this mean for the future? And how do we plan accordingly? And so there's some articles here, and I'm going to send these to Phil so that you all can read them. I encourage you to do so. One was written in the New Yorker from a doctor who works at Henry Ford. Her name is Dr. Rana Audish, and she is a pulmonary hypertension ICU specialist. And essentially what that means, she works with the most complex people with lung issues. And she wrote an article called Coronavirus and Inequity Meet in Detroit. And it is a phenomenal article. I encourage you to read. And it really talks about health disparity and inequity and how that collided with a virus that we weren't prepared for and why it hit everyone so hard. The other thing is that there's a link here for from, I believe it's from Harvard Business Review. It's talking about the discomfort you are feeling is grief. And grief comes in many different ways. And people were grieving the loss of what was routine life, grieving that they were having to separate themselves from their families just in order to do their work. And then there is a song that I love and that someone sent to me, and it's called Singing You Through. It's the United States Navy Band featuring Heather Nova, and it's phenomenal. If you've got some earbuds, put them in, sit back, close your eyes, and listen to this. It's a pretty phenomenal thing. But on the path forward for Henry Ford is everything related to science. Besides caring for patients, one of the things we're trying to do is do what we can to bring both the best practice on how we care for patients, as well as additional modalities, vaccines or other drugs that can help care for these patients. One thing we learned early on, we had patients in the ICU, is they had what they said we learned is that proning patients helped. And what proning means is that they have you on your belly as opposed to on your back. And what that did is it took some of the pressure off of the lungs. And so it was very unusual for people, especially young doctors, going through the ICU and seeing all their patients on their bellies. So some of the innovation that I was referring to was about old school medicine, things that had been learned, decades ago, was being brought back to say, we're going to try everything that we can to see what we can do. And there is a study, and it did hit the news last week and this week, that Henry Ford is the only health system in the state that is participating in it. It's called the COVE study, and it is the Moderna vaccine. And they are now accepting apps for people to get the vaccine, and will be participating in a nationwide study. And this is a phase 3 clinical trial study. And what that means is that if it reaches efficacy in its phase 3, it goes to mass production to the population. And so this is a very important study. And this is not the only one. There are other phase studies out there, but this is the one that Henry Ford Health System is participating in. So I'll jump into the next subject and why these two matter. But before I do that, I just want to pause for a second and see if there are any questions that I can try to answer. I just threw a lot of information at you.
What does efficacy mean in terms of the trial?
It means that it has already gone, it is a double-blind study, which means so you have a placebo group and a group that's actually receiving the vaccine. And it has gone through, there are 3 phases that it's required from, and again, I'm not a clinician, so forgive me if I get this wrong, but there are 3 phases that it has to meet efficacy to say that there is enough data to indicate that it is providing the positive outcomes that you're looking for in order for it to continue to move on to those phases. So if I understand correctly, they're looking for 30,000, I believe, people to participate in this. And in the very first day, our numbers were significantly higher than we expected them to be for people wanting to participate. Yeah. And once they get to if I understand correctly, once they get to that number, and I believe it's 30,000, they will stop the double-blind piece of the study and they will just move into the full portion of the study because they will already have had enough of those who are receiving the placebo and who are not. Good. So if you go to Henry Ford or go out to to Cove Study or the Moderna vaccine, you'll be able to find a lot more information on this. But I think part of it is, talking about taking care of the community, talking about what we're doing for each other, and then what are we trying to do in the scientific realm here to bring an answer to the broader population of the country and the world for that matter. And lastly, before I move on, if any of you are NPR fans, my husband is an NPR junkie, as I like to call him, nerd, whatever that might be. This American, they were embedded with Henry Ford for a couple of months. And there's a 4-part series out there called The Reprieve. And it is phenomenal. And what it talks about is what was it like from being in the hospital and rendering care? What is it like from a patient or the patient's perspective? And what it was like as it relates to what happened in the city. It's one of the things that occurred very early on, is there was a faith-based breakfast that occurred that had a lot of faith-based leaders from the city at it. And many individuals who attended that event became ill and lost a lot of significant individuals. And very early on in this, there was a colleague from Henry Ford. I worked with him, well known, very high profile in the city of Detroit, was one of the very first that we heard of that we lost to COVID, a young man in his 40s. And it literally just dealt a huge blow to the organization and to the city. And so I encourage you to take the time. It's a 4-part series. It's just extraordinary. Okay. Good, Will. All right. So how the intersection happens here too. So I happen to sit on the board of directors for Hospitality House and Food Pantry. And I stumbled across this place a long time ago and couldn't quite figure it out. So we live in Commerce. And when we first moved out here, I worked at Henry Ford West Bloomfield Hospital. And I would drive kind of a little bit of a back way to get to the hospital. And there was this building that didn't have a sign on it. And but I would see people early in the morning standing in line out in front of it. And I couldn't figure out, I'm just curious. It's right next to a furniture refinisher place. And I'm like, what is this place? And it took me forever. And I finally had a neighbor told me it's called Hospitality House. I'm like, oh, okay. So I looked it up and it's a food pantry. And I'm just going to expose myself here a little bit, was a bit taken aback about the fact that there was a food pantry in my community. And then I kind of checked myself and thought, Jane, why in the world would you be surprised? And because my husband and I had worked really hard to live where we live, and we'd saved a lot of money, and I had this false sense of, everyone who lived here had means. And fast forward years later, and when I left my consulting job, I had some time on my hands before I went back to Henry Ford, and I wanted to volunteer. And so I had found them online, and I completed an application for volunteering. Still didn't call me. I'm like, man, I can't even volunteer. This is getting rough around here. So, so they did get in contact with me last year and asked me if I was interested in being on the board. And one of the things about them that is so true is that they see the face of hunger every day in the pantry. It's located on Maple right here in Commerce Township, right by between Welsh and M5. And I'm just going to tell you a little bit about the Hospitality House and why what's happening with COVID and this work intersects with each other. So the pantry was established in February of 2002. It's private, it's non-for-profit, an equal opportunity human service provider organization. It serves families that are at or below 200% of the poverty level. What makes it unique, and one of the reasons why I'm so passionate about it, it's a client choice pantry. And what that means is we're not just handing out a box of food and saying, here's what you get based on what we have. They can come in and shop, and they can shop with integrity. It's like going to Kroger. It doesn't look as fancy as Kroger, but it's like going to Kroger. There are carts. You go through and you choose what you need. It is the largest food pantry in Oakland County, and it is open on Mondays, Thursdays, and Saturdays for people to shop. And so this is a place that has captured a bit of my passion and my heart for the community and my desire to give back. The services that it provides is emergency food service, again, for people who are at 2% or 200% below the poverty level. It also provides emergency transition shelter. So for people who are between housing options, they have secured housing, but they don't have a place to stay right now. And they can, we have funding to be able to put people up for 30 days in a hotel in order to keep them from being homeless. And also emergency car repair assistance, and it's called Pit Stop. And the whole idea behind the emergency car repair piece is that if you don't have a car, you can't have a job. If you don't have a job, you can't pay your bills. You can't pay your bills, you can't feed your family. And so trying to really help people with the intersection of all of those needs. The food, where does the food come from? Community donation is 40% of it. 41% of it is coming from government agencies, so the Emergency Food Assistance Program and the Certified Food Support Program, I believe it's called. And then we purchase food from Gleaners and Forgotten Harvest and Myers for gift cards. On a monthly basis, 550 households are served, and that's 13,144 people. 38,000 pounds of food monthly go out. And we have, just between March and June of this year, we've served 142 new households. That's an increase of 37% of new clients just in the last few months. And that has a lot to do with the COVID crisis.
Yep.
The primary service areas when they started had to do with, was Walled Lake, Wixom, and Novi, but we don't limit it to that. We have people as far as Trenton, downriver, and Fowlerville coming in for food, and we're not turning folks away if they qualify based on household needs. Then they get food. Most of the clients are female, single, and are working age. 42% of our clients were new to the pantry last year. So let's just sit there for a second and think about this. This is pre-COVID. The economy doing pretty well in 2019, and continue to see a larger increase of new clientele during that time. Almost 50% of people are on some form of Social Security as their primary income. 22% have none at all. And then you get into some of the working poor piece of this, right? 15% full-time, 11% part-time. And 5% have just miscellaneous resources and how they get that. But those are the demographics of the people that we serve within the community. And their finances, the revenue, as you can see, the numbers are tight, right? Bringing in $570,000, and that's all mostly through fundraising. And expenses are slightly above what's coming in. Administrative costs are very low. There's one full-time person who's the director and other part-time people and mostly volunteers. And 90% of the income comes from individuals, corporations, school districts, churches, all the fundraising. And why this becomes important, especially in light of the COVID crisis that we've had, and we're not out of it. We're seeing a bump up this summer, and we're going to see a return. We're predicting maybe 50% of what we saw in March and April and May, we'll see again in October and November. And so when finances are down, especially now as evictions can occur, the unemployment supplement has ended. I believe something else will come, but it is right now there is a break in that. And we will continue to see an increase in need. You've got people moving in together to try to keep resources combined. And so you've got young children to elderly individuals living in the same household. And so the spread of the virus goes up, and the need for food and life-sustaining supplies continue to go up. And right now, people are feeling very generous. Corporations, everybody's into the fundraising mode, right? Wanting to do good, wanting to feel better about doing their part. But this will slow down, and the need is still going to continue. And so I just encourage you to know that places like this exist in the community. They are always interested in any fundraising support that can be done. But I would encourage you to get the word out. This is sadly a fairly well-held secret. It took me, I live here, it took me a long time to find out who they were and what they did. And they're working very hard to get the word out, and we've robustly added to our board and working very hard. But we can't, a lot of the fundraising activities that you'd normally be doing have all had to be halted. No golf outings, no, things being held at pubs, all that kind of stuff.
Yeah, Rotary has the same problem.
Yeah.
In raising.
Yep. And so, this has been my term ever since I embarrassed myself because I couldn't believe that there was a food pantry in my community. This is the mantra I have held on to then, and that is hunger doesn't have a zip code. And it can happen to any one of us. And it is what I love about Hospitality House is the integrity that is at the core of all who come in and have a need and those who serve. So with that, that is all I had prepared. Is there any questions I can try to answer for you all?
I have a couple of questions
Turn off your share.
Sure.
that may not fit the timing, but I just have a question in mind, and it might relate to other people's attitude as well, but that's the telemedicine method of whatever, seeking relief from whatever the problem happens to be. I'm wondering if there's a twofold problem with telemedicine, and one is for at least some people, they may not feel comfortable talking by phone to a doctor, needing treatment, or even just general questions, whatever. And the other part of that is that there are a number of people in any environment that are limited in some fashion, that they may not be able to use a Zoom method or whatever of being able to contact a clinician to find out if they have a problem that can be solved that way. Any comments in that particular area?
Sure. The whole idea is that we meet you where you're at. And so if you can and are comfortable with that modality, doing it in an electronic format, and you consider that safer than coming into a clinic, that offer is there. The clinics are open, and even during all of the crisis, they remained open. Doctors would bring patients under the abundance of caution if they didn't have to expose you. Say you had another patient coming in who was sick but didn't know what they were sick with. They were trying to make sure that if you were healthy enough to keep you healthy and not have you exposed. But traditional ways to be seen by physicians continues to exist, and that's not going away. But what we are finding is that folks were avoiding care because of the concern. And so being able to provide it in a telemedicine environment met that need, as opposed to them not going without care completely.
That's a great comment. I appreciate that. And the other question that I had was relative to the statistics. There's been a fair amount of commentary in the media lately, let's just say within the last few weeks, about the statistics that have been published previously are changed by review of the files, whatever they use to find out whether they're original reporting was accurate or not, and then changing things. And in some cases, it seemed to me that there was almost an alarming report from a couple of months ago that was changed by review. And today, it would be looked at quite differently. So my question comes to the idea of the validity of the original reporting. Is there some level of control, if you want to call it that, when reports are given that a death occurred because of, is it truly COVID or is it something else that COVID implemented or assisted, something along that line? But anyway, can you just talk a little bit more about the generality of statistics and how they change over time?
I'll do my best. This is, again, not my area of expertise, but I'll give it a try. I think one of the things that we all need to remember is that this hit us far faster than we expected, and it required people to pull together and start to collect data and report on data in an environment that had not otherwise been organized. And so over time, you learn. Right, as a community, we expect and demand information deeply rooted in data as often as we can get it. And so reporting numbers becomes really important. I would say from a hospital perspective, so I'll talk about Henry Ford Health System, how we were documenting COVID positive, suspected COVID, who died of the COVID disease versus, other discharges or other deaths. Those practices didn't change. That's routine things that you would do within a health system. How those numbers get aggregated and get reported out by a county or by a state environment, I think that they were learning as they were going, and we've tried hard, and I think that this becomes really important for all of us. It's the whole. They were doing the best that they could at the moment. And there were a lot of people being pulled together to do things that were not their traditional responsibility, or they'd never seen it before. Maybe it was part of a responsibility for me, but I've never gone through something like this before. And so I would say in the medical community also, I've heard a lot of conversations and read articles that indicate that we have seriously underreported deaths related to this, because you have a lot of non-witness deaths. People were dying at home and there was no one there with them. And so I'd say the state of New York is still continuing to say that they believe that their numbers are underreporting because of those reasons. People were so afraid to go to the hospital. And so the emergency services in our communities were actually rather quiet. And I work with a lot of emergency room doctors who would say, where are all the heart attacks and strokes? Where are those patients? Because they would normally be coming in and they weren't coming in. And so I don't think I'm giving you a very good response, because I don't know that I have one, but I would say that if anything, it is my thinking would be that we're underreporting. And we just need to be really careful about what that means.
Thanks, Jane. That's good. Any more questions, folks?
I have a question. Jane, this was an excellent presentation, and I'm so glad that I was able to sit in today. I work with the Lakes Area Rotary Club, as well as West Bloomfield is my home club. And Novi, and I'm thinking that there might be something that we, all of us collectively in this area, could do to support Hospitality House. And in fact, I know that Lakes does support Hospitality House. Lori McVeigh has been, I think, very involved with Hospitality House on her own. The question I have is, obviously, money is monetary donations are important. Do you accept food donations as well?
Yes, they do.
So if we worked with you to find out what kinds of things were needed and accepted, we could do kind of an area-wide food drive as a service project for our Rotary clubs. And I think that would be doable in this time where we can't do much of anything else, but feasible. So,
Great idea.
yeah,
Absolutely.
I think we all work together to do this. Who would we talk to at Hospitality House?
I'm happy to put you in touch with the individuals who manage the fundraising, you know, just like you all, right? There's a small cohort of people who do a lot of the different jobs. And so I'm happy to put you in touch with them, but they're some pretty passionate folks that have been at it for a long time and have gotten really creative given the fact that we can't do some of our traditional fundraising right now.
I would love to see if we can't collectively, all of our clubs in this area, work to support that. I think that would be great. And I know the need is great. West Bloomfield, I know, is.
Yeah, and absolutely. And my husband and I dropped by the pantry over the weekend because we had some things to drop off that we wanted to get to a foster care shelter. And still to pull around the back and see the cars all lined up waiting. And at the height of this, those cars were lined up out onto, and the Hospitality House is tucked back in. It's in an industrial sub kind of area. It's tucked in the back area. And so this is real stuff every day. Yeah.
So maybe Phil, you can, maybe we can communicate.
Absolutely. Yep, because I'm going to send some of these links to Phil by way of email, and he can get them out to all of you for some of the resources, and then I'll add in the fundraising folks from Hospitality House.
Great, thank you.
Excellent. Well, any more questions? Lynn? Bruce?
I had another one, but at my age, they escape quickly.
Oh, listen, bud, happens to me all day long. Thank you very much for having me. It's been a pleasure meeting you, and I hope that our paths will cross again in the near future.
Sure they will. It's an excellent presentation, Jane. Thanks.
Okay. Thank you. Thank you for your time. Stay
okay,
well,
guys.
everyone.
Just remember, this recording will be available maybe within the half day, something like that, but it'll be up soon.
Perfect.
Okay, I'm going to end the meeting. We won't ding the bell, but here we go.
Ding, ding.
Thanks, guys.
Thank
Bye,
you.
guys. Thank you. Thank you.